enzymes that will aid in the digestions as well as absorption of nutrients in your body. Digestion, which is food being broken down into absorbable molecules. And lastly, absorption, wherein nutrients, electrolytes, and water are absorbed or transported from the lumen to the GIT to blood to anywhere in the body. So here are the main organs. You have the main organ as the oral cavity, the oropharynx, the esophagus, the stomach, and the intestine. You will have another laboratory discussing the gross anatomy of your accessory organs, which includes your salivary gland, your spleen, your pancreas, the liver, the gallbladder, the kidneys, and the suprarenal gland. Although in today's laboratory, we will have a slide about salivary glands as well. So the first part, which is the oral region. The oral region comprises of the lips, the oral cavity, your teeth, your gingiva, the tongue, the palate, and the palatine tonsils. All of these parts of the oral region, you should know what are their parts. Right? So let us start by understanding the oral region part, which is the lips. The lips is a mobile musculofibrous fold surrounding the mouth. And all of us knows where the lip is. Its action is to grasp food, to suck liquids, to keep food out of your oral tubule, and to form speech as well as osculation. And these are the parts that you should be able to know. Starting with the philtrum, the Cupid's bow, the vermilion border, and the oral commissure. So you should be able to know these parts of the lips. What is the blood supply of the lips? I know that you know that via your lecture of the gross anatomy. And we have your superior labial branch of your facial artery, as well as the infraorbital artery of the maxillary artery. That is for the upper lip. The lower lip is from the inferior labial branch of the facial artery, as well as the mental artery branch of the maxillary artery. So those are the blood supply of the lips. It is innervated. The upper lip is innervated by the superior labial branch of the infraorbital nerve, while the inferior lip is innervated by the inferior labial branch of the mental nerve. So I hope you are able to grasp those information that are needed with regards to the lips. Let us go now further to your oral cavity. The oral cavity is where food is ingested and prepared for digestion by the act of mastication and lingual manipulation. It is divided into two, the oral vestibule and the oral cavity proper. Oral vestibule, which is this one. Wait. The oral vestibule and the oral cavity proper. All right, the oral vestibule is a slit-like space bounded by the lips and cheeks and externally and internally by the teeth. Okay, so what are the boundaries of it? Of course, the lips anteriorly, laterally, the cheeks or the buccinator, posteriorly and medially, the teeth and the gum. Now, there are several parts in the oral cavity that you should take note. And what are those? First, the opening of the parotid gland. A small papilla in the mucosa opposite the upper second molar marks the opening of the parotid gland. And it is pointed here. That is the opening of the parotid gland opposite the second molar on the upper teeth, okay? The upper second molar, opposite it is the opening of the parotid gland. The sublingual papilla. All right? You have a sublingual fold, and this sublingual fold is a small ridge on each side of your frenulum lingua. This is your frenulum lingua. This is a median fold of mucus connecting the undersurface of your tongue to the floor of the mouth. That is your frenulum lingua. Now, there is a sublingual fold, which is a small fold on each side of your frenulum. And this is raised by the sublingual gland. The sublingual gland is making the raise of the sublingual fold. The medial end of the fold, this one, represents the sublingual papilla, which is where the opening of the submandibular duct will be located. All right, the sublingual papilla. The opening of your salivary glands, sublingual and submandibular, will be found on this sublingual papilla. I hope it is clear. Now, part of your oral cavity are the teeth. I know we're not dentists, but we still have to know how many teeth are deciduous and how many are permanent, because you ought to know this kind of things. You have 4 kinds of teeth. You have an incisor, you have 8 incisor, you have canine, you have 4 canine, you have premolars and molars. All right? And it makes a total of 32 as a permanent teeth. Now, of these 4 teeth that you have, the strongest and the sharpest is the canine. It is the one used for tearing your food. The premolar and the molar, because of their flattened top, it is more for munching. All right? For pulverizing the food that you eat. So again, the sharpest teeth is the canine, which is used for tearing apart the food that you eat. All right? Now we all know what is the function of the teeth. And the teeth is being supplied by the superior and inferior alveolar arteries, which are branch of the maxillary artery. The venous drainage goes by the same name, superior alveolar and inferior alveolar as well. Innervated by the same name, superior alveolar nerve and inferior alveolar nerve, all coming from your trigeminal nerve. Okay, so I hope that is clear. We now go to the next part, which is the palate. The covering of your palate on the superior side is the respiratory mucosa. And what is the respiratory mucosa? Pseudostratified columnar epithelium. Inferiorly, it is the oral mucosa. So therefore, it's stratified squamous. There are 2 regions of the palate, the hard palate, which is anteriorly located, and the soft palate, which is posteriorly located. The anterior 2/3 of the bony skeleton is formed by the palatine process and the palatine bone. And of importance here is the incisive papilla overlying the incisive fossa. Why? This incisive fossa is a depression in the midline of your bony palate posterior to the central incisor canal. And this is where your nasopalatine nerve will pass through. That's why it's important. All right? So, the nasopalatine nerve will be passing through the incisive fossa, which is found here. The innervation of your palate is by the maxillary nerve, both of which initially pass through your pterygopalatine ganglion. Okay, so that is the innervation. The blood supply of the area is by the spinopalatine artery of the maxillary artery and the descending palatine artery of the maxillary artery. So those are the innervation and blood supply of the area. Now let's go to the muscles of the soft palate. What muscles are found in the palate? So we have 5 muscles. The palatoglossus, palatopharyngeus, palatoglossus, tensor veli palatini, and the levator veli palatini. So what are the importance of these muscles? First, let us discuss the tensor veli palatini, this muscle. This muscle originate from the scaphoid fossa of the medial pterygoid plate, inserting into the palatine aponeurosis. It is innervated by the medial pterygoid nerve of the mandibular nerve. What does it do? It tenses the soft palate as well as opens the mouth during swallowing and yawning. So that is the purpose of your tensor veli palatini. How about the levator veli palatini? This one. The levator veli palatini originates from the pharyngotympanic tube, inserting again to the palatine aponeurosis. It is innervated by the vagus nerve. What is its action? It elevates the soft palate during swallowing or yawning. So it elevates. This one opens, this one elevates. Okay, so make sure you know what are the purposes of these muscles that are found in the palate. Next is the palatoglossus. This one. The palatoglossus originate it came from your palatine aponeurosis going to the side of the tongue. And it is innervated by, again, the vagus nerve. What does it do? It elevates the posterior part of your tongue. Elevates the posterior part of your tongue and draw the soft palate into the tongue. So it goes the soft palate down towards the tongue. So that's the purpose of your palatoglossus. How about the palatopharyngeus? This one. It inserts into the hard palate aponeurosis as well as the lateral wall of the pharynx. Again, innervated by vagus nerve. So what does it do? It pulls the walls of the pharynx for swallowing. So for you to swallow, this muscle has to contract. The palatopharyngeus muscle. The last muscle is the musculus uvulae. This one at the middle. The musculus uvulae came the posterior nasal spine going to the palatine aponeurosis. It is innervated again by the vagus nerve. What does it do? It shortens the uvula. So it pulls it up superiorly. So therefore, these are the 4 muscles of the soft palate. They are all innervated by the vagus nerve except for the tensor veli palatini. Except for the tensor veli palatini, they are all innervated by the vagus nerve because the tensor veli palatini is innervated by a branch of the mandibular nerve from your trigeminal nerve. All right? So I hope that is clear. What are their purposes and what are they for? Now let's go to the tongue. In the tongue, you have to know where are the location of your papilla as well as the specific location of your tastes. All right? So, do not pay attention on the location of the papilla on this tongue because they are incorrect. Go to this image. That's why it's important for you to be discernful of what you read from the internet because not all of the ones that you will be discerning for the location of the taste centers. So we have bitter, sweet, salty, and sour. You have to know where are they located. As medical student, you have to know. That is why, as you can see, sweet and salty are in the front. That is why we tend to love food that are sweet and salty. And turn to the spice food, which are sour and bitter. Okay? So the location in our taste, the taste buds or the tongue, in the tongue, tells our preference for food. Okay? Now, how about the papilla? The papilla, these are where your taste buds are located. Okay, so where are they located? So the valate or the circumvallate is on this part of your tongue, or the circumvallate papilla. They are large and flat tapped and are located in this location. The foliate papilla are located in the serrated area, this area. They are small lateral folds. The filiform is located in the tip of your tongue, which are long pinkish gray projection, which are sensitive to touch. Sensitive to touch, the filiform papilla. They are the one responsible for your tongue being sensitive to touch. Fungiform are the pink-red spot, which are at the apex or the margin of the tongue. And this is where the fungiform papilla are located. Okay, so make sure you know the location of your papilla. Okay. Let us now go to what now is the blood supply of your tongue. It is being supplied by the lingual artery, being drained by the lingual vein that ultimately drain into the internal jugular vein. How about innervation? It's important for you to know the innervation of the tongue. All right? The muscles of the tongue, except for the palatoglossus, because palatoglossus is innervated by cranial nerve 10. All other muscles of the tongue are innervated by cranial nerve 12. Okay? Cranial nerve 12. Now, on the other side, you can see that the tongue, for general special sense, is innervated by the glossopharyngeal nerve or cranial nerve 9. All right, that is for the posterior third of your tongue. For the anterior 2/3, you have lingual nerve or cranial nerve 5 for general sensory, and cranial nerve 7, which is chorda tympani of the facial nerve, for special sensory. So you have to take note of what innervates the tongue. Okay? All muscles of the tongue are innervated by the hypoglossal nerve or cranial nerve 12, except for the palatoglossus, which is innervated by vagus nerve. Now, when it comes to sensory, the posterior third is being innervated by cranial nerve 9 or the glossopharyngeal nerve, while the anterior 2/3 is by the cranial nerve 5, lingual nerve of the cranial nerve 5 for general sensory, and for special sensory, it is the chorda tympani of the facial nerve. All right, so you have to know those facts about the tongue. So what are the tongue muscles? We have two kinds. We have an intrinsic muscle and an extrinsic muscle. When we say muscles, they are the one that changes the shape of your tongue. When you want to curl your tongue, that's the one that, the intrinsic muscles are the one responsible for that. Now, how about the extrinsic muscle? The extrinsic muscles are attached to the bones and the soft palate. And you have four. You have genioglossus, you have genioglossus, You have hyoglossus, styloglossus, and palatoglossus. Okay? So these are the 4 muscles of the tongue which moves it. So the genioglossus, this muscle, protrudes your tongue. The hyoglossus retracts and depresses the tongue. The styloglossus retracts and elevates the tongue just like the palatoglossus. Okay? So those are the responsibility of each of the tongue muscles that you have. So make sure that you take note of it. Salivary glands. You have 4 salivary glands. You have your parotid gland, you have your sublingual gland, you have your submandibular gland, and your accessory glands or the small accessory glands. They are all capable of secreting your salivary juices. Okay? So what is the purpose of the salivary glands? It keeps the mucous membrane of the mouth moist. It lubricates your food as well as begin digesting starch because of its amylase. It is also an intrinsic mouthwash. You don't need mouthwash. The salivary glands are acting it. It prevents tooth decay and heightens your ability to taste. And you have 4. The parotid gland, which is a purely serous gland. The submandibular gland, which is a mixed gland. The small accessory gland, which is a mixed gland. And the sublingual gland, which is a purely mucous gland. So those are the 4. So where does the parotid gland opens to in the mouth? Where does the parotid gland opens to?
Upper second molar
First
teeth.
to second molar.
Opposite the upper second molar. Very good. How about the submandibular and the sublingual gland? Where does it open? Where does it open? Your sublingual and
Sublingual
Lingual
papilla.
papilla.
in the
Sublingual
sublingual
papilla.
at the medial side of your sublingual fold. That is where you will find the opening of the submandibular and sublingual gland. All right? So make sure you know that. We now go to the nasopharynx. The pharynx are divided into 3 parts, and the other pharynx part are part of your respiratory tract. But the nasopharynx, the oropharynx, sorry, this is incorrectly labeled. Let us change that. The oropharynx is part of your gastrointestinal tract. And this is the oropharynx. Okay, the yellow one, that one is your oropharynx. The oropharynx is involved in the voluntary and involuntary phases of swallowing. So both voluntary and involuntary swallowing. Your oropharynx is involved into it. All right? So remember that. Now, the oropharynx is around 2 to 3 centimeter wide and 3 to 4 centimeter long. And it is situated behind your oral cavity. Okay? Now, in this area, you will find the Waldeyer's ring. Right? So, important for you to know the Waldeyer's ring. Okay? Now, what is the Waldeyer ring? It is a ring of lymphoid tissue in the naso and oropharynx formed by the paired palatine tonsils, the adenoid tonsils, and the lingual tonsils. So, 3 tonsils make up the Waldeyer ring. Okay, let us now show the Waldeyer ring. There, that is your Waldeyer's ring. It's a ring of lymphoid tissue in the nasopharynx and oropharynx. This oropharynx is supplied by the external carotid artery branches, namely ascending pharyngeal artery, as well as branches of your facial artery, lingual, and maxillary artery. its drainage is via the pharyngeal venous plexuses. So again, the Waldeyer's ring is formed by the pharyngeal tonsils or the adenoids, tubal tonsil, palatine tonsil, and lingual tonsils. Okay? The pharyngeal tonsil, when it is enlarged, you call it adenoids. Adenoids, when the pharyngeal tonsil is enlarged. Okay? So remember that. So how many tonsils makes up the Waldeyer's ring? You have 4. Paired tubal tonsils, paired palatine tonsils, and your pharyngeal tonsil and your lingual tonsil. They are collectively known as the Waldeyer's ring. It is a location which usually gets infected often. I don't know how many of you have had tonsillitis in the past. These are the location of those tonsillitis. And some of us are very prone to have it. Some have the tonsillitis 3 to 4 times a year. Well, if you have more than that, you have to remove the tonsils because it is better to remove it than to have complications arising from often having the infection. All right? If it is removed, there's nothing that is done in harm into your body. The next is the esophagus. Esophagus is just a transport organ. It just transport food going to the stomach. It begins at the level of the cricoid cartilage. So that's at the level of C6. And descend posterior to the trachea, leaves the thorax through the esophageal hiatus of the diaphragm, and terminates by entering the stomach at the cardial orifice, which is at the level of the T11. Okay? So, it is from C6 to T11. That is the range of your esophagus. Okay? This esophagus has 3 constrictions and they are identified here. Those are your 3 constrictions. Okay? So, the first constriction is called the cervical constriction, and it is made by the cricopharyngeal muscle. It is the uppermost and the narrowest. It's the narrowest, around 15 centimeter from your incisor. It's the most common site of obstruction, the cervical, because it's the narrowest and the uppermost. The next is the bronchoaortic, which is at the level of T4, T5. This is where the main stem bronchus and the aortic arch are located. They are the one causing the constriction. All right? So it is 1.6 diameter and 22 centimeters from your incisor. The last constriction is in the diaphragmatic area, around T10 to T11. It is the diaphragmatic hiatus, which is the lowermost, and it is caused by the gastroesophageal sphincter. So it's the gastroesophageal sphincter that caused the constriction. The uppermost by the cricopharyngeal, the second by the mainstem bronchus and the aortic arch, the third by the gastroesophageal sphincter. So those are the constrictions which are location for obstruction in the esophagus. Now, the esophagus has 2 sphincter, an upper esophageal sphincter and a lower esophageal sphincter. The upper esophageal sphincter is an anatomical sphincter. Okay, it's just between the pharynx and the esophagus. It is produced by the cricopharyngeus muscle. It is normally constricted to prevent entry of air into your stomach. So you don't get too much air. It is closed most of the time. The lower esophageal sphincter here is a physiological sphincter. So the upper esophageal is an anatomical sphincter because of the cricopharyngeus. The lower esophageal sphincter is a physiological sphincter. Okay? There is no sphincteric muscle. The sphincter is formed by four phenomena. So there's a sphincter because of four things. One, the acute angle of the stomach. Because the angle of the stomach is acutely placed, thus there is a sphincter. Next, there's a positive intra-abdominal pressure that compresses the esophagus. So the intra-abdominal pressure causes the sphincter. And third, the folds of the mucosa aid in occluding the lumen at the gastroesophageal junction. And lastly, the right cruise of the diaphragm, which creates a pinch cock effect. So four things happen to have a physiologic sphincter. One, the acute angle entry of the stomach. Two, the positive intra-abdominal pressure. Four, the folds of the mucosa. And lastly, the right cruise of the diaphragm. Okay? So I hope that is clear. I hope so. So these are the constrictions as we have identified a while ago. And the sphincters as well. Now, there is a ligament called phrenicoesophageal ligament. Phrenicoesophageal ligament. It connects the esophagus flexibly to the diaphragm. And this limits the upward movement of the esophagus while permitting some movement during swallowing and respiration. So it keeps the esophagus in place, the phrenicoesophageal ligament. Okay? All right. So the blood supply, you have here the supply of your esophagus, the drainage, the lymphatic, and the innervation. I suppose you know all of this from your theoretical part. I don't pay attention to this much because we are laboratory. All right. We now go to the next organ of the gastrointestinal system, which is the stomach. The stomach has three parts. It has a cardia, a fundus, and a body. It has also a pylorus. So the cardia is the superior opening or inlet. It is at the level of T11 to T12. The fundus, this one, is the dilated superior part related to the dome of the diaphragm, while the body is the major part. It is between the fundus and the pylorus. All right. So the stomach is said to be an expanded part of the digestive tract, which means mainly functions for chemical and mechanical preparation of your ingested food for digestion. It's served like a blender or a reservoir. Okay? The pylorus of the stomach, you can identify the pyloric antrum, which is the wide part, the pyloric canal, which is a narrow part, and the pyloric ring or orifice, wherein a sphincter is located to control the discharge of stomach contents into the duodenum. Curvature. The lesser curvature is a shorter concave right border, also known as the angular incisor or the angular notch. It is where you will find the angular notch or the angular incisor, which is the junction of the body and the pylorus. So the junction of the body and the pylorus is the angular incisor. And then you have the greater curvature, which is a longer convex on the left border of the stomach. Okay? As for the relations of the stomach, I give that to your lecture already, as well as its relationship. So as you can see here, the stomach has two omentum. It has a greater omentum and a lesser omentum. Okay? The stomach is covered by peritoneum, except where the vessels run along its curvature and at the area of the cardial orifice. Okay? Now, the lesser omentum, this is the lesser omentum. The lesser omentum has 4 layers. These 4 layers of peritoneum will divide into 2. So 2 layers of omentum will separate to extend around the stomach and come together again to leave as the greater omentum. Okay? The greater omentum is a prominent 4-layer peritoneal fold that hangs down like an apron to the greater curvature of your stomach here. Okay? While the lesser omentum is also a smaller but four-layer peritoneal fold as well, which connects the lesser curvature of the stomach and the proximal part of the duodenum to the liver. So it connects it to the liver. It also connects the stomach to a triad of structures that run between the duodenum and the liver in the free edge of the lesser omentum. Now, it's important for you to know what are the ligaments that comprise this lesser and greater omentum. The greater omentum is composed of the gastrocolic ligament, meaning stomach to colon, gastrosplenic ligament, stomach, spleen, and gastrosplenic ligament, stomach to diaphragm. All right, so those are the 3 ligaments that comprise your greater omentum: gastrocolic, gastrosplenic, and gastrosplenic. While the lesser omentum is hepatoduodenal ligament and hepatogastric ligament. So hepatogastric ligament, this is that ligament, and hepatoduodenal ligament, this one. So in this hepatoduodenal ligament, you will find your bile duct, hepatic artery, hepatic vein. That is where portal vein, you will find it in here, in the hepatoduodenal ligament, which is one of the ligaments comprising your lesser omentum. Okay? I hope that is clear. So again, how many ligaments will join to form the greater omentum?
3.
How many ligaments?
3 ligaments.
3.
3 ligaments. Okay? It is gastrosplenic, gastrophrenic, and gastrocolic. While the lesser omentum is only 2, hepatoduodenal and hepatogastric ligament. Okay? So I hope that is clear. Oh, this is just a repetition. So this shows now your greater omentum. As you see, it looks like an apron hanging at the anterior portion of your GIT. Okay? While the lesser omentum is also a 4-layer fold found from the lesser curvature going to the liver. The stomach bed. Stomach bed is just where the stomach will lie. Okay? And superior to inferiorly, you will find the left dome of the diaphragm, the spleen and the splenic artery, the left kidney, and the suprarenal. That is what you will find when you remove the stomach, also known as the stomach bed. Now, what supplies the stomach? It is the celiac trunk. What drains the stomach? The right and left gastric vein drains to the hepatic and portal vein. Okay? And it's important for you to know what will comprise your portal vein. Your short gastric vein and the left gastroepiploic vein drain into the splenic vein and joins the superior mesenteric vein to form the portal vein. Okay? So again, your short gastric vein and your left gastroepiploic vein will drain into the splenic vein. The splenic vein and the SMB will join to form your portal vein. Okay? Now, what is the innervation of the stomach? Parasympathetically, it is via the vagus nerve. Sympathetically, it is via the celiac plexus through the greater splanchnic nerve. So, whether it is sympathetic or parasympathetic. Okay? So I hope the stomach is clear. Let us now go to the small intestine. The small intestine is 6 centimeters long, 6 meters long. It is the longest part of the GI tract. It is from the pyloric orifice to the ileocecal fold. Okay? So it has three parts: the duodenum, the jejunum, and the ileum. This is the ileum. Okay? So, bulk of your chemical digestion and nutrient absorption occurs in the jejunum. Bulk, most of your digestion and nutrient absorption occurs in the jejunum. While vitamin B12 absorption happens mostly in the ileum. Okay, so I hope that is clear. We have duodenum, jejunum, and ileum. You have to differentiate how you will know their when they are presented to you. So the duodenum, it's easy. The duodenum is C-shaped. All right, that is the duodenum. It is comprised of four parts. If you have a superior, descending, inferior, and ascending part. Again, superior, descending, inferior, and ascending part. The first part of the duodenum is the widest, has the widest lumen. It is C-shaped. Okay? And you have your hepatoduodenal ligament connected to it. Okay? So the superior part, this one, is at the level of L1. The superior part of your duodenum is at the level of L1. It is approximately 5 centimeter long. The descending part is from L1 to L3. L1 to L3. It lies to the right and parallel to your inferior vena cava. So it's to the right of your inferior vena cava. Inferiorly around the pancreatic head. So as you can see, your pancreas are here. All right. Now, the major duodenal papilla is the opening at which bile and pancreatic secretions enter from the ampulla of Vater. Okay? So you have a sphincter, although I don't have a slide showing the, the duodenal papilla. So rest assured, I will not ask about it. But you have to know that there is a major duodenal papilla where the ampulla of Vater will enter. All right? The minor duodenal papilla is being controlled by the sphincter of Oddi. I hope you have heard of these parts of the duodenum. The inferior part, it is the longest section and it is crossed anteriorly by the superior mesenteric artery and vein. So a while ago, it was to the right. Now, it is now crossed by the SMB. All right? And the last part, which is the ascending part, is from L3 to L3 or L3 to L2. Okay, it is after the duodenum crosses the aorta. So the aorta, when it crosses the aorta, that is the ascending part. Okay, here's where you will find the ligament of Treitz at this part. So again, the 4 parts of the duodenum: superior, descending, inferior, and ascending. And now go to the jejunum. The jejunum is 2/5 of the small intestine. Okay, it comes from the duodenojejunal flexure. While the ileum, which ends at the ileocecal junction, is 3/5 of the jejunal ileal part. Now, the important thing in jejunum and ileum is for you to identify the difference of them. First of all, in location, hypogastric is your ileum, umbilical is your jejunum. The walls of your jejunum are thicker and more vascular. So that's the most important part. If you see a thicker intestine, small intestine, and more vascular, then it must be a jejunum. Now, the circular folds or the valves of Kirk-Ring, they are longer and closely set in the jejunum. In the ileum, they are spaced out. The villi are larger and thicker in the jejunum. And there are no Peyer's patches in the jejunum. It's only found in the ileum. The mesentery of the jejunum contains less fat and somewhat semi-translucent. The vasa recta called the peritoneal windows. While in the ileum, there is no peritoneal windows between vasa recta. So what are we talking about? How do they look like? This is how they look like. So this is your jejunum. It has longer vasa recta, while the ileum has shorter vasa recta. Okay, that's one comparison for them. And your jejunum, if you will find it, it contains less fat. There are less fat in the jejunum. Okay, so that's the main difference between the two. The longer vasa recta is found in the jejunum. More fat is found in the ileum, as well as shorter vasa recta. Okay, so I hope that is clear. So we have here a table showing the vasculature, drainage, lymphatics of the small intestine, which is more of a theoretical thing rather than a laboratory thing. So we go now to the large intestine. The large intestine is where water is absorbed from your indigestible residues of the liquid chyme, converting it into a semi-solid stool or feces that is stored temporarily and allowed to accumulate until defecation occurs. The large intestine is 5 meters long and it consists of these parts. You have a cecum, appendix, ascending colon, transverse colon, descending colon, sigmoid colon, rectum, and anal canal. So these 8 parts comprise your large intestine. So how will you know that it is the large intestine already? Because you will see epipicloic appendages or omental appendage. You see small fatty omentum-like projections. Aside from that, you see haustration. This one is called haustration, the sacculation of the wall of the colon between tinea. And this is a tinea coli. There are 3 tinea coli. You have a mesocolic tinea, you have an omental tinea, and a free tinea. Okay? I'm just so sad that you weren't able to notice this or to observe this in the cadaver because you might not forget about it when you see one. Omental tinea and the free tinea. So first, the cecum. Cecum is the first part of the large intestine. It's a blind intestinal pouch, approximately 7.5 centimeter long. It is in the right lower quadrant. And if this is distended with feces or gas, the cecum may be palpable through your anterolateral abdominal wall. Okay? Now, what is noticeable in the cecum? It is where your appendix is located. Do you see this? These are the possible location of the appendix. The cecum has no mesentery because of its relative freedom. Okay? And the appendix, which is called vermiform appendix because it looks like a worm, arise as the posteromedial aspect of the cecum. Okay? The appendix has a triangular mesentery called mesoappendix. Now, the position of the appendix is variable, but the most common location of it is retrocecal, and this is retrocecal. That is the most common location of the appendix, retrocecal. Okay, retrocecal. The cecum and the appendix is being supplied by the superior mesenteric plexus or innervated by the superior mesenteric plexus. All right, and it is being supplied by your ileocecal artery as a branch of your SMA, superior mesenteric artery. Okay, so again, take note, the most common location of the appendix is retrocecal, 64% of the time. And this is the appendix. This is where you can see the appendix. As you can see, there is a mesoappendix or a mesentery attached to it. Okay, now we go to the next part, the ascending colon. The ascending colon is the second part of the large intestine. It is narrower than the cecum. It is retroperitoneal along the right side of the posterior abdominal wall. And it is covered by peritoneum anteriorly. Okay? The greater omentum separates the ascending colon from the anterolateral abdominal wall. It is being supplied by the right colic arteries, drained by the right colic veins, and innervated by the superior mesenteric nerve plexus. Let us go now to the most movable part of the colon, which is the transverse colon. The third and the longest and the most mobile part of the large intestine is the transverse colon. It hangs at the level of L3. Okay? It is being supplied by your middle colic artery, the right and left colic artery, being drained by the superior mesenteric vein, and innervated by the superior mesenteric nerve plexus. So it's easy because they all are the same. The descending colon, this part, it is also secondary retroperitoneal. Okay, retroperitoneal. Just like your ascending colon. The sigmoid colon is S-shaped. So this S-shape is the sigmoid colon. It has a long mesentery called the sigmoid mesocolon. Therefore, it has considerable freedom. Okay. Now, the tinea coli disappears at the level of the sigmoid colon. Okay. It disappears. So in the rectum, it is now replaced by longitudinal muscle. Okay. Now the rectum. This is now the rectum, this part. It is at the level of S3 or third sacral vertebra. It terminates at the level of the anorectal ring, which is at the level of your puborectalis sling or dentate line. And this rectum follows the shape of your sacrum. It ends as an expanded section called the rectal ampulla. This is where the feces are stored, in the rectal ampulla. The rectum has no tinea coli. It only have longitudinal muscle around it. Okay, so remember that. The anal canal, this is the anal canal, is the inferior opening of the anal canal in the perineum. Okay, it's the rectum of your gastrointestinal tract. So that's the rectum. Let's go to the anus. So what are the important parts that you have to know about the anus? You have to note the columns of Morgagni. The columns of Morgagni, or also known as the anal canal. These are it. These are vertical folds produced by the infolding of the mucous membrane and some of the muscular tissue. Okay. Then you have the pectinate or dentate line. All right. So you have the pectinate or dentate line. The pectinate or dentate line divide the upper 2/3 and the lower third of the anal canal. And then you have the anal sinus. The anal sinus is superior to the valves. Superior to the valves are called the anal sinus. When compressed by feces, the anal sinus will exclude mucus, which aids in the evacuation of your feces. Okay? So what is important to know about this anal canal? They are anal sphincter. You have an external anal sphincter and an internal anal sphincter. The internal anal sphincter is an involuntary sphincter. While the external anal sphincter, this is the one that you control. Okay? So, you have two sphincter in your anal canal. That is why you don't just poop. All right? You don't just poop. You poop intentionally. All right? So, that is the last slide for the gastrointestinal system, the anal canal. So, I hope you are able to remember the important parts of the gastrointestinal system's gross anatomy. And be prepared when I ask you about it in the exam. All right? So again, read your books, your anatomy books, to reinforce what you've learned for today. Is there any question at this point? Quiet means no. All right, if there are no questions, that ends our laboratory for today. I hope you have learned something and you will remember what you've learned in our discussion. Okay?